she does not complain of dysphagia or dyspeptic symptoms, but she complains of excessive sweating. And she has palpitations, shortness of breath.
Lamia. No. Now, this is not systemic inquiry. These are all symptoms related to the presenting complaint. But these are all parts of the present history of the presenting complaint. This is not serious. Yes, the symptoms are serious, but you don't find these things on systemic review. These are all part of the illness. Ne? So this doesn't come under the systemic review.
Yes.
Okay, carry on.
She has palpitations and shortness of breath when walking a short distance and when speaking about 2 to 3 sentences. She has also hospitalized once with sudden onset chest pain, drowsiness, shortness of breath at rest. Later, she was.
No, wait. Hey.
Uh,
What do you think would have happened?
she has had atrial fibrillation.
It is some sort of cardiac problem, right? Yeah.
Yes.
It could be fibrillation. It could be what else? What else could it be?
Uh,
She has. What else can it be? It could be
now,
No. Now this, let's see what happened. Hospitalized, one sudden onset chest pain, drowsiness, shortness of breath at rest. So what else could it have been? It could have been atrial fibrillation, yes. What else could it be? She needed ICU care as well. So that
yes.
means fairly severe. So what else could it have been? Anybody can answer. What else could it have been? What are the
Recording
other
in
common things that
progress.
happen?
Heart failure.
Yes. Heart failure. All right, carry on.
And her family members.
These are not neurological symptoms. These are neurological symptoms, but these are not systemic inquiry.
Okay.
Hurry.
Her family members have noted that she has been irritable more than usual, and she complains of insomnia, tremors of hands, and eye changes like heaviness and bulging of eyes.
Okay.
And she has had loose stools 2 to 3 times per day, and she has had irregular she has no oligomenorrhea, but she has had irregular menstrual cycles since puberty. And she has no proximal muscle weakness, but she has bilateral leg edema over the shins. And after that, she is followed up at National Hospital, and she has no past medical problems other than this condition. She has no family history of thyroid diseases and no known allergies. And now she is on carbimazole 15 milligrams 3 times per day.
So was this started at the NHSL?
Yes, sir.
I think so. Nikam followed up So
yes,
she
sir.
was treated at NHSL with carbimazole only.
That was the only drug she could remember, sir.
No, remember
Yes.
So what are the drugs may you think about? Will you think about what are the drugs will you think about?
Problem beta blockers.
Yeah, that's right. Okay. Why do you think this particular patient will need beta blockers?
For symptom control.
Yeah, that's right, exactly. So what are the symptoms, the main symptoms due to?
Palpitation.
That those are the symptoms we are talking about. But what causes those symptoms?
Sympathetic overactivity.
Yeah, exactly. So if you are treating a patient with Graves' disease, you must always remember you have to treat the symptoms first. So therefore, carbimazole alone will not do, no. History hari taranna ti prashne ne. Kaudu e prasan karan lamaya nama?
Dharma Vijay.
Dharma. Mandan na kaudu gil. Hari. Okay. Balu. Yang. Okay. Carry on.
And her conditions has had a negative effect on her daily activities of daily living, such with tremors and palpitations.
Yeah.
But these symptoms had responded to treatment. Her nearest hospital is Kiribati. That her emergency episode has initially managed at
Kiribati. Okay.
Kiribati, and then she
Fair
was
enough.
transferred to Ragama
Okay.
for
Fair
ICU
enough.
care.
Okay. Fair enough. And
Sir, we took the history over the phone, sir, so we couldn't examine. But
ඒක හරියන්නේ නැහැ. ඒක තමයි ඔය ප්‍රශ්න අඩුවෙන් no, no, okay. Let's go back to the history. What are the other things that you need now if you are going to do a systemic review in a patient like this? What are the other things that you should have asked? Now you say you are going, no, whatever the story that you said is not about systemic review.
yes,
The
sir.
story is all symptoms of excessive thyroxine production. Colonel. So, what are the systemic review questions that you can ask? Hmm? You asked about, so what about the respiratory system? What else might she have? If she had the episode of cardiac failure, what do you think she might have had?
Uh,
What are the
Almost,
questions? Sorry?
uh,
Anybody can answer. Huh? Can. What other questions do you think you could have asked? Come on, man. You are talking about the cardiovascular system, ne? And
yes, sir.
yes. So, what are the other questions you may have asked?
Other heart failure features such
Exactly.
as
Yeah, exactly. Like what?
orthopnea, paroxysmal
Right.
nocturnal
What are the other
dyspnea.
things? Now, what are the common things that will happen? Yes, orthopnea, paroxysmal nocturnal dyspnea. What else? All right. ඒ වගේ you should ask some more questions. Right. Okay. කමන්න ඒක අන්න ඒවයි systemic review එකට එන්නේ. තේරුණාද? These
Yes,
what you described is all feature. This is all those are part of the presenting complaint because those were the complaints that she had with the current illness. Okay. What is the other question that you have not asked? A critical question. Hmm? When she described these symptoms, what is the other critical question that you have not asked? It's a very basic question.
Other autoimmune condition?
No. Weak simple question ekadda modi. No. Lamia, did she notice a lump in her neck?
Sir, I asked that, but she said she did not.
Okay,
No.
so then you must mention that. You see? So do you normally get a goiter in people with Graves' disease?
So there can be a diffuse
No,
diffuse
there
in
can be any blood in the sky also may come down. In a normal patient with a Graves' disease, do you normally get a goiter? When Graves described this disease, who is Graves, by the way? Who is Graves? So everybody can find out who Graves is. Huh? I will ask you one day. Then you must know the answer. Okay. Who is Graves? And so did he describe a goiter with his patients? Because if you are going to use somebody's name and describe a disease, the classical features described by the original person must be there in your patient.
yes.
Otherwise, you can't call it that, no? So did Graves have the patients that Graves described have a goiter? Or normally, is it common to have a goiter or not? That's a very important thing to find out. No? Your patient may not have had. Who is going to talk next? Or only you're talking?
So,
Who is
so
person? Who is the other person?
Dharmasena. She's
Do they normally have a goiter?
No, sir.
No, they do. Yes. Normally, usually Graves' disease should have a goiter. Not a very big one, a small goiter. Okay, the original description of Graves was in young women with a goiter and the other features that you all have described. So that was the original description. So when you call it by some name, you must make sure that all the classical features are there. Anybody with excessive thyroid hormone in the circulation is not Graves' disease. What is the definition of Graves' disease? What is the definition of Graves' disease? Hmm?
Mm. It is an autoimmune
Yes, autoimmune.
uh, condition involved in the thyroid gland
All
causing
right.
primary thyrotoxicosis.
Mm-hmm. A lot of words. Yeah. So yes, it is a immunogenic thyroid disorder resulting in what? Various features. So that is Graves' disease. So okay. Right. Okay. So on examination, if you took the history on the phone, what have you listed here then?
So we
Oh,
so we went through her records. So
yes, yes. All
this
right.
is the summary of
Okay.
what we
Okay.
found.
Okay. Okay. So go ahead. Correct.
So in summary,
Hmm.
uh, this is a 33-year-old previously healthy female who presented with loss of weight for 2 months
No.
duration.
Are isal are symptoms are signs alten? Or reality when you කියන්නේ අන්න ඒක හරි කියෝගෙන යන්නේ ඉතින් on
Uh,
examination.
uh, on examination, I would expect a thin waisted.
And I would expect නෙමේ Modi then you said you went through the records and it's
Yes,
recorded no so how
yes.
can you expect anything so what was found in the record
She was found to be thin and had eye signs such as exophthalmos, lid retraction, lid lag, and ophthalmoplegia. And
oh very interesting ophthalmoplegia also I wonder so what do you okay exophthalmos how do you check for exophthalmos
um,
okay before that how do you elicit eye signs properly
mm,
what are the requirements
patient has to be in seated position and
where is
head
the examiner
examiner should be in the in a side of the patient, looking from the side.
හොයි කවුද ඔය බහුභූත හොඳ වෙලාවට මං ඇහුවේ examiner also should be seated in front of the patient the eyes should be at the same level please remember පැත්තේ ඉඳලා මොන බම්බුවක් කරන්න you can be to a side slightly to avoid confusion but you must be able to observe directly no පැත්තේ ඉඳලා පේනවාද තේරෙනවද කියන්නේ
Yes.
so you are seated at the most important thing is your eyes and the patient's eyes should be at the same level තේරෙනවද
Yes.
if you're standing below the patient, then you won't see it. What are the features of early exophthalmos? What do you notice? How do you recognize early exophthalmos? Anybody can answer. How do you recognize early exophthalmos?
So lid lag.
No, lid lag is a different physical sign. We are talking about exophthalmos. How do you
Sclera
recognize?
below the limbus.
Yes, right. Sclera can be seen below the limbus. That's correct. That means early exophthalmos is observed with the lower eyelid. At the level of the lower eyelid, you can see the sclera below the limbus. That is correct. Did you all understand that?
Yes.
When you look at the eye is with the lower eyelid, the eye is white between the lower lid and the limbus, pupil area. Okay. So that is called early exophthalmos. When it is obvious, then it will be both upper and lower eyelid. But early exophthalmos, you must notice with the lower eyelid. Okay. Lid retraction. You know how to do it. Lid retraction is obvious. You can see it's retracted. Lid lag. with the finger going up and down. Again, you must steady the patient's head. The patient's head is moving up and down. You cannot do lid leg. Okay. And why does lid leg happen? What is the cause of lid leg?
Overactivity of levator palpebral superioris.
So why is
Because
it? Why does it overact?
it has sympathetic innervation.
That's correct. Correct answer. Because of sympathetic innervation, levator palpebral superioris part of it is in spasm. So the leg, the lid can't come down at the same speed. Yes. Ophthalmoplegia. I see. Now, ophthalmoplegia. I don't know which muscles were paralyzed. Nobody
That
knows. No, that's the thing. So, what are the likely things that will get paralyzed that you'll be able to observe easily? Hmm. What sort of things will get paralyzed so that you'll be able to easily observe? Paralysis of which muscle? Hmm? Anyway, find out. We are not. What is meant by chemosis? Lamea, Dharmaja Lamea.
is
What is meant by chemosis?
Excessive redness of the
Yes,
sclera.
kind of eye irritation, sir.
Yes. Sign of redness. Increased redness is called chemosis. Lots of people don't know. They just write these things, but you have no idea what it means. So remember the critical things about eyes at the same level, reasonable distance from the patient, maybe slightly to a side, and steady the head. Then only you can observe all these physical signs. And each one means a different thing. And you must be able to elicit these things properly. Otherwise, it is useless. Okay. Just doing it will not do. Okay. So on examination, what did you? There is a goiter. What is it?
Yes, sir.
Solid nodule. What is left lobe. So normally Graves will have a goiter. Not necessarily a nodule. It's usually a diffuse goiter.
Yes.
But even this patient has had a small nodule on the left lobe. Okay. Wasting of small muscles in the hand. Why? Why would that happen? What do you think? No, normally. So when you talk about wasting of muscles, what are you trying to say? What sort of problem are you trying to talk about in Graves' disease?
Proximal muscle wasting.
Yeah, myopathy. So myopathy doesn't happen in small muscles of the hand.
Yes.
If small muscles of the hand are wasted, what are you thinking about? What sort of lesion are you thinking about? I'm not sure that this is correct.
Carpal tunnel syndrome.
කවුද? මගේ ළඟ හිටියනම් ඔලු ගෙඩිය පලාගෙන කවුරු හරි. Carpal tunnel syndrome නෙමෙයි ළමයා. Carpal tunnel syndrome causes some wasting in some muscles, but no. If you usually see small muscle of the hand, in general, what sort of lesion are you talking about? What is the main segment that supplies the small muscles?
Ulnar nerve.
Ulnar nerve විතරක් නෙමෙයිනේ දෙකම කරනවානේ. But yes, but what is segment? Spinal segment.
T1.
Exactly. Yeah. So if you see wasting of small muscles in the hand, you must wonder whether this patient has a problem with C8 T1 lesion. So you have to think about something like that. I don't know whether this finding is correct or not. It may be she anyway has small hands. I don't know. Sweaty. Okay, carry on.
She has had sweaty palms and tremors noted in hands. Okay. And her heart rate.
How do you look for tremors in a patient with Graves' disease?
Ask the patient to extend arms and outstretch arms and then observe.
Exactly. අර කොල කැල්ල තියන්න එපා බනිනවා කියලා කිව්ව කවුදනේ? ඒක තමයි. කොල කැල්ල බොරු කතාවක් නේ. මොකද ෆෑන් එක යට කොල කැල්ලක් තියලා. දැන් කොල කැල්ල සට සට ගාලා හෙල්ලෙනවා. Because of the fan, not because the patient has. So no. You don't. If you watch carefully, but the patient must relax the fingers. When you have a tremor, tendency is to tighten the fingers. No. Yes. So unless you relax the hand, outstretch, relaxed hand, then only you will notice the tremors properly. Okay, right. Okay.
She has had tachycardia and irregular pulse.
No, irregular pulse. So if you are saying irregular, you must say what sort of irregularity. What is the characteristic irregularity?
Irregularly irregular.
Yeah, due to?
Atrial fibrillation.
Correct. Atrial fibrillation, irregular pulse. Okay. So those are the things to look for. Okay, go on.
If it is complicated with heart failure.
I don't know. Did this patient have?
Yes, sir.
This heart neme. So this patient has. So if he has fine basal crepitation, that may be a sign of heart failure. Bilateral ankle edema. I thought you said no, maybe pre-tibial mixed edema. Was this edema pitting or not? Danne edema liyanne mehema nemeya. ඔය එකක් එන්න ඕන. තේරුණාද? bilateral ankle edema ලියන්නේ ඔහොම නෙමෙයි. හරිද? Yeah. Pre-tibial mixed edema. Has anybody seen? No. It's a very rare thing. I'm not sure. This girl may have had, I can't remember. So pre-tibial mixed edema is a very rare thing. Okay, carry on.
So in summary, this is a 33-year-old previously healthy female who presented with loss of weight for 2 months, and she is clinically hyperthyroid and has features of thyrotoxicosis.
Yeah. Now these terms, hyperthyroid means what?
She has excessive thyroxine.
No. So in that case, what is thyrotoxicosis?
Hyperthyroidism due to thyroidal causes.
Right. Hyperthyroidism means overactivity of the thyroid gland. Thyrotoxicosis means?
Excessive amount of thyroid hormones in the circulation.
That's right, due to any cause. But the main cause is usually the thyroid. So don't get confused with these terms. Okay, when you say hyperthyroid, that means the thyroid gland is overactive. Thyrotoxicosis means excessive amount of thyroxine in the circulation due to any cause, but the commonest cause is also the thyroid gland. Okay, so you can't, when you use these terms, be careful. Okay, right, okay. Carry on. මේ බේසික් ඉන්වෙස්ටිගේෂන් කියලා. මේ ලෙඩාට මොකටද FBC CRP කරලා තියෙන්නේ මොකටද? liver profile මේ පිස්සුද?
Sir, as
නෑ මන් දන්න ඕවා කියවන්න එපා මට ළඟ හිටියන ඔළුව පල්ලා මම මෙහෙම කරන්නේ නැහැ. I don't believe in this basic. You will do investigations to find out something specific. If you think a patient is anemic, do a hemoglobin. If you feel that a patient has an infection, bacterial infection, you should do a white count. If you feel there is a problem with the kidney, do a renal function test. Blood, if you think that this patient is likely to be diabetic, and because mehema karala kawurut balannet there's no point. But the most important bits are here: T3, T4, TSH. Yes, carry on. Carry on. Oh.
Yes, sir, as this patient.
Basic rubbish. Anyway, right. Okay. Thyroid function test. Okay.
Thyroid function test, we can do a TSH.
No, you can do. I can. It has been done, no? So this patient had thyroid function test. Did she have thyroid function test?
Yes, sir.
So where are the results? You don't know.
Don't know, sir.
So what do you expect a TSH?
We expect to have low TSH and high T3 and T4 levels.
Which one will go down first? Which will happen first? Low TSH.
First it is T3 and T4.
Is it? You're sure about this? So in other words, you can't have where the TSH is low and T3, T4 normal. You can't have that.
Cancer.
Cancer.
So then what is that called?
It's subclinical.
Exactly. So therefore, the first thing that will happen is the TSH will go down. Why is that? What is the reason for TSH is the one that will change first? Because even in subclinical disease, you T3, T4 normal, but TSH is low. Why is that?
The T half of the TSH.
No. The reason is that TSH is a far more sensitive index of the thyroid pituitary axis. Okay. And a little change will cause a big change in TSH, whereas little changes in T3, T4 will not be noticed very much. Okay. So TSH is far more sensitive. Okay. Ultrasound of the neck. Okay. Carry on.
Sir,
Okay. Oh, go on.
yeah, sir, I'm not sure whether this patient is fine needle aspiration cytology.
නැත්තයිද අපි මොනවද කරන්නේ? මට කරන්න දෙයක් නැහැ ඒකට. Wait. Carry on. Assessment cardiac function.
Uh, then assessment of cardiac function has been done by.
Okay. Why were you worried about the fine needle aspiration or fine cytology?
Because sir, in the records the
නෑ record කතාවක් නෙමෙයි මං අහන්නේ මේ theory මගුලක් නෙමෙයි. Now here is this patient and you want to specifically talk about the needle aspiration cytology. Why? මොකද මේ ලෙඩාගේ what specific thing makes you think that she should have a needle aspiration?
Goiter.
He had a solitary nodule.
Nodule, that's exactly quite right. The moment you see a solitary nodule, what should you think about?
Neoplasm.
Very good. Usually you should think about a neoplasm. It could be benign, it could be malignant. Okay, so therefore, in this patient, it is worth mentioning that you are not sure about the fine needle cytology report. So that's okay, but I think she should have one, particularly because there is a nodule. Okay, fine. Go on. Assessment of cardiac function.
Cardiac function, ECG, 2D echocardiogram.
Why do you want a 2D echo?
Because,
why do you think?
She might
Yes,
have.
නෑ ළමයා මේ theory මගුල් නෙමෙයි මේ ලෙඩා. Why do you think this patient definitely needs a echocardiogram?
She has features of heart failure.
Absolutely. She has been in the ICU admitted with heart failure, very likely, and atrial fibrillation. So in a patient like that, there is a definite indication for a echocardiogram. It is very relevant. In everybody you want to. So you are not theoretical level නෙමෙයි. This particular patient, what is relevant to this patient first. Then we can discuss general things later. Okay. Chest X-ray, what are you looking for?
Pulmonary edema. Consolidations, bilateral.
You won't be at home, no? If she has pulmonary edema. Anyway, that's okay. Chest X-ray. Yeah, but what are other things? Yeah, okay. What are the features you have to look for?
Cardiomegaly.
Yeah, cardiomegaly. That's right. It could be cardiomegaly. And features of pulmonary
Heart failure.
Heart failure. Exactly. Right. So that sort of thing you will look for in a chest X-ray. Okay, go on.
And we can and she has undergone specific diagnostic tests for Graves, but they are not routinely done. The TSH receptor antibodies, thyroxine peroxidase antibodies.
Wait. How in the cake? This
Yes,
what do you know about these antibodies against the thyroid? What are the common antibodies against the thyroid gland?
TSH receptor antibodies.
Where is that? Where is that antibody located? Where does it act against?
In the act against the TSH receptor.
Oh, where is that TSH receptor?
The thyroid.
මන් දන්න thyroid නැත්නම්
thyroid
බෝඩියේ gland නැතියේ කවුද මෙම ළඟ කනෑනෙමු gland එකේ නැත්නම් heart එකේ නෙවෙයිනේ. That is correct, but where? Now okay, let's follicle you මේ කියන follicle එකේ තමයි follicle එකේ කොහෙද? Inside the cell, outside the cell, in the nucleus, on the cell. Sorry? Somebody answered. Can't buy na tu. I can't hit no. What do you say? It's on the surface. Remember, okay, let me anyway, it's like this. Remember, there are three main antibodies for the thyroid gland. One on the surface of the cell, and that is the TSH receptor antibody. Where is there another? It's on the surface. Hurry. Next to the blood vessels. So it comes directly to that one. Then there is one inside the cell in a place called the microsome, and that is called microsome. What is the function of the microsome? What is the function of the microsome? Lamai? Suddenly everybody had disappeared. I think they have run away. Dharmaja Lamaya, what is the function of the microsome? May uttare
I'm
metana.
not sure.
Sorry?
I'm not sure.
I am not sure it's not the function of the microsome. Who told you? Lamaya, no, that's a place where hormones and things are produced. Hormones, enzymes and things are produced. So that is why thyroperoxidase antibody is also called antimicrosomal antibody, and that destroys the cell. One against the membrane, one against the cell, and what is the third one called? What is the third component in the thyroid follicle? You have a cell with a membrane, you have microsome, and what is in the middle?
Nucleus.
Sorry? No, not in the
Nucleus.
cell, man. No, not the middle of the cell. I am talking about the middle of the follicle. What do you get in the middle of the follicle?
Thyroperoxidase.
No, thyroperoxidase.
Colloid.
Colloid. So what is that antibody called? What is that? What is the name of that colloid? What is the colloid found in the thyroid, man?
Thyroglobulin.
Ah, thank you very much. Thyroglobulin. So the antibody will be called
Antithyroglobulin
antibody. So those are the three main antibodies you must remember about the thyroid. TSH receptor on the surface, microsomal or thyroperoxidase antibody inside the cell, and antithyroglobulin antibody in the middle against the colloid. So it all three can act. Okay. Unfortunately, in lots of immunogenic thyroid problems, all can be positive. But if you really want to confirm that it is Graves' disease, which is the test? Which of these will tell you that it is definitely Graves' disease?
TSH receptor.
Yes, because what happens in Graves? What is the basic mechanism in Graves' disease?
Hyperactivity of the thyroid gland
How does it happen, Lamia?
due to stimulation of the cells.
Oh, so how is the cell stimulated?
No, TSH receptor antibodies.
Right, yeah. TS receptor antibody comes and sits on the receptor and then stimulates the cell. So therefore, if you want to diagnose Graves' disease, the test is what?
TSH receptor.
Antibody positivity. That's it. That's right. Thyroperoxidase may or may not be positive. Thyroglobulin may or may not be positive. So that doesn't matter. Hmm? So if you want, now what is the other condition which might cause hyperthyroidism?
Toxic multinodular goiter.
Yeah, multinodular goiter, but a diffuse goiter. In both, you get a diffuse goiter. In Graves and the other condition, you get a diffuse.
Early stages of autoimmune thyroiditis.
Very good. Early stage of autoimmune thyroiditis. Now, the main issue would be to decide, is this Graves or early stage of autoimmune thyroiditis? So what is the test you're going to do? What can you do? Does the TSH receptor antibody anything to do with autoimmune thyroiditis? Lamai? The answer is no. Okay. So TSH receptor antibody is more or less specific for Graves. So to differentiate between those two conditions, you can do a TSH receptor antibody. Okay. The test test that is more sensitive for autoimmune thyroiditis is thyroid peroxidase antibody. Okay, thyroglobulin antibody is not very specific. It can be present or absent, but that is how you differentiate. Did you understand that? Good. Right. Say isotope scan. Yes, you can do. No. Now, if it is Graves' disease, what do you notice on isotope scan? What will you notice? You should notice.
And uniform uptake.
Yeah, I know. So when you look at a normal scan and this scan, what will you notice?
Increased uptake.
Good. Yeah, diffuse, uniform, increased uptake. That's what this means. There's increased uptake. Okay, there is hyperactivity. That's what we expect. Ne? because the antibodies are stimulating. Okay, so you can do that, but that is not done. You don't need to do that. Once you have all the other investigations, very rarely will you need. So, okay, now this also can differentiate between autoimmune thyroiditis and Graves' disease.
Graves.
Now, in autoimmune, what do you expect? What happens in autoimmune thyroiditis? What is the basic mechanism? What does the thyroperoxidase do to the thyroid cell? Lamai, very simple, ma'am. Simple answers. Basically, what does it do? Does the cell produce more thyroxine?
It increases the release of thyroxine
No. Yeah, how does it increase the release of thyroxine? Huh?
Destruction of
by
cells.
Yeah,
degranulation.
no, wait. What did you say?
Destruction of the cells.
Very good. The thyrocyte is destroyed. So, what will happen to the I131 uptake then?
Reduced,
Yeah, of
diffuse
course.
reduction in
See,
uptake.
it's a nice picture, isn't it? In Graves' disease, you have a high uptake. In autoimmune thyroiditis, it will be low uptake diffusely. So it's very nice. You can differentiate between these things. Okay, carry on. Hari. දැන් අර මේ ධර්ම සේනල මේද දැන් කරන්නේ?
Hello.
ආ? කවුද
Um,
කවුද ප්‍රසන්ට් කරන්නේ?
no, sir, they are there.
අද තමයි හෙට හරි කමන්නේ නැහැ. කවුද ප්‍රසන්ට් කරන්නේ?
Vikram.
අප්පට සිරි. කමන්නේ හා කරමු. Go
Uh,
ahead.
this patient presented with features of thyrotoxicosis and associated.
So what does that mean? What does that mean, Vikram Singh? Thyrotoxicosis?
That means his serum level of T3, T4 level are above the normal.
Thyroid hormone කිව්වම ඇතිනේ excessive amount of thyroid hormone in the circulation. That's what it means. Okay. And but in this patient it is also hyperthyroidism. Yeah, okay. Go ahead.
And the main clinical types of thyrotoxicosis are diffuse toxic goiter, which means Graves' disease, and toxic nodular goiter, toxic nodule, and hyperthyroidism due to rare causes like TSH secreting pituitary adenoma, lymphocytic thyroiditis.
You think that lymphocytic thyroiditis is a rare cause? Huh? What is lymphocytic thyroiditis? What's another name for lymphocytic thyroiditis? That's what's meeting in your make a varadia. What is lymphocytic thyroid? What's another name for lymphocytic thyroiditis?
Hashimoto thyroiditis.
Exactly.
Autoimmune thyroiditis.
Yeah, autoimmune Hashimoto thyroiditis. So the common causes are diffuse toxic goiter, toxic nodular goiter. Then you have to put Hashimoto's thyroiditis early stage. Then you can put rare things, other things. Okay. So there are actually three main things: toxic goiter, toxic nodular goiter, and Hashimoto's. And then you have this toxic nodule, maybe autonomous, maybe non-autonomous, but it doesn't matter, toxic nodule. Okay, all those things are there. So remember, don't forget, maybe autoimmune thyroiditis is not a rare thing at all. Huh? The main problem is people mistreat this like Graves' disease because there is excess hormone in the blood, but they actually haven't got Graves' disease. So you can't treat Graves and Hashimoto's the same way because the mechanism is completely different. So it's very important to understand that. Okay, carry on.
Graves' disease is mainly an autoimmune condition.
නෑ මම අර ඉස්සෙල්ලත් ආව වික්‍රමසිංහ කවුද මේ Graves කියන්නේ? මේකට apostrophe එකක් එන්න ඕන. ඒ මනුස්සයාගේ නම Graves. The apostrophe S apostrophe. හරිද? හරියට මේවා ලියන්න ඕන. Right. Automatically. Okay, carry on. Carry on.
And the most common cause of endogenous hyperthyroidism.
Correct.
It usually affects younger women with peak instance of 20
what
to
is the
40
importance
years
of saying that? What is so therefore what is the other condition that we mentioned just now causing hyperthyroidism? What is the other condition we just mentioned?
Hashimoto.
Right. So What age group does the Hashimoto affect? Who gets Hashimoto? Old again, koi wage? Oyage vayas hitara?
More than
Kauda manusyo.
around 50 years.
So what is that age called?
Middle
Middle age.
Middle-aged females. That's right. So it's very important to differentiate. Usually younger, but older women also can get Graves' disease. There's nothing to say they can't, but much more common in younger. How old was your patient, Dharmajay?
33, sir.
Yeah,
33.
so it fits into this group, no younger group. Okay, carry on.
It has a ratio of 10 to 1 woman compared to the male.
No, Puta, window, hold it. If you talk about thyroid disorders in common, thyroid disorders are 10 to 1 common in females than in males. Why? All thyroid diseases, 10 times more common now, 8 times more common now in women than in men. Why? Why do you think? Lamai?
Due to autoimmune.
Not due to autoimmune. Why can't autoimmune things occur in men also? Why do you think? Why do you think these things happen? Why is it?
Because they present.
No, Lamai. What's the major difference in the internally between men and women in terms of causing this sort of problem? It is the hormonal environment. That is the answer. The hormonal environment is completely different in man and woman, and thyroid problems therefore are far more common in females than in males. Okay, all, including Graves' disease. Okay, carry on.
The 50% of patients have a
frequent
family.
eye signs, but remember, frequently. So what do you mean? How frequent? If you take 100 people with Graves' disease, how many are likely to have eye signs and how many may not have eye signs?
Almost all.
Now, almost all Varadi. Find out. It is a large percentage that will have eye signs, but you can get, that's important to remember, you can get Graves' disease without eye signs. So that's the problem. That is where you will need all the investigations to prove that it is Graves' disease. Okay, carry on.
50% of patients have a family history of autoimmune endocrine diseases.
Yeah, that is not wrong. Yeah, lots of people have a family history suggestive of autoimmune disease. Okay.
And it affects the whole functioning thyroid tissue.
Why do you put that sentence there? To differentiate from what? නිකං ඔය කොහෙද නෑ පුතෝ ඕක දාලා තින්නේ කොහෙද පොතකින් කොපියක් ගහගෙන ඔතනින් ලියලා ඒකයි. So what is that? But there's an important message. What is that? In what condition will certain parts of the thyroid gland not be contributing to the toxicity? So
toxic nodule.
Yeah, one is toxic nodule, the other one is, come on. Toxic multinodular goiter. The nodules will contribute, the involuted parts in between will not. So to differentiate that, only this sentence is there. Okay, carry on.
There are mainly 3 autoantibodies.
Right.
Graves' disease is mainly associated with ophthalmopathy and dermopathy.
What is meant by dermopathy? What do you get? Dermopathy කියන එකේ තේරුම මොකද්ද? Pretibial myxedema, all of you know, in front of the shins, in front of the leg, you can see. Dermatopathy මොකද්ද? What is the dermatopathy?
So due to deposition of
නෑ පුතෝ ඔය බහුබූත කියවන්න එපා. What is meant by dermatopathy? What is the මොකද්ද dermatopathy එකේ තේරුම?
Disorders associated with skin.
Very good. Disorders of the skin. So what are the disorders of the skin that you might notice in a patient with Graves' disease? What are the disorders of skin that you will notice? And you must look for them and ask questions also. What are they? Hurry up, somebody, quickly. All of you know this. This patient.
Vitiligo, sir.
Yes. Commonest one is vitiligo, whitening of the skin. What are the others? What is the other common thing that this patient had it? Come on, man. This patient, this girl had that problem. Very common.
Pretty
Sorry?
well.
Sorry?
Pretty well mixed with it.
මොකක්ද කියේ? මට තේරුන්නේ නෑ. ළමයා, this is a very common problem. Lots of ladies complain about this. What is that? And a clue, a lot of ladies complain about this. What is that? Because you all don't think in a skin එකේ අනික් components මොනවද? One is the
Sweating.
surface. No, sweating is not a dermatopathy. Ne? Sweating is to do. Sorry, then itching maybe, but itching is not that common. No.
Color changes.
Color
Black
change. Why vitiligo කියන්නේ ඒකට තමයි body. White skin කියන්නේ ඒකට තමයි. No. What is the other component of the skin that all of you have forgotten?
Subcutaneous tissue.
No.
Hair falls.
Ambo, thank you very much. Loss of hair. Yes. So you must actually නිකම් වචන කටපාඩම් කරන්න එපා. This is your problem and you have absolutely no idea what to ask or what to look for. Yes, loss of hair is a common problem. That's part of dermatopathy. That's right. What is this thyroid acropathy? Where will you look at these things?
Fingers. Hand.
In the hands and where?
Hands.
Yes.
Fingers. It's like
Yes.
clubbing of the fingers.
Yes, clubbing can be there. Yes, it's the distal part of the fingers. That's where you look for this acropathy. Loss of nails, clubbing, various other changes in the distal part of the fingers. Okay, carry on. So,
They are associated with other autoimmune disorders.
Maybe.
Disorders like
Vitiligo is not another autoimmune disorder. It is part of the same problem. Okay, right.
myasthenia gravis and type 1 diabetes mellitus.
හරි නිකන් ඵලය. ඌ දැකලා ඇති බම්බු. මේ නිකන් කොයිද පොතකින් කටපාඩමක් ලියාගෙන ඇවිල්ලා. Right, carry on. Go on. Carry on.
And they are having eye signs.
Listen, eye signs are not only in Graves' disease. You can have exophthalmos without Graves' disease in other countries. So don't say things like that. You know, acropathy, of course. Acropathy, of course, only in thyroid disease, pretty well mixed. Eye signs is not specifically Graves' disease, but lots of people with Graves' disease will have eye signs. So don't miss. You can have non-Graves exophthalmos. Please remember that. There are conditions like that. But pretty well mixed edema and necropathy, yes, they are specific for Graves' disease. Okay, carry on.
In management of
how list එකක් ගහලා වික්‍රමසිංහ හොඳ වෙලාවට ළඟ නැත්තේ පුතෝ ඕම නෙවෙයි. Graves' disease, what is the main form of management of Graves' disease?
Medication.
Yeah, it's, please remember, Graves' disease is not a surgical problem. Graves' disease is managed by drugs in most people. Okay, tell me a little bit about management with anti-thyroid drugs. Vikram Singh, go on, explain about anti-thyroid drugs.
We can go with anti-thyroid drugs.
පොතකින් කොපියක් ගවට මූ ළඟ හිටියා නම් එහෙම. First of all, what is the anti-thyroid drug that you are going to use? What is the anti-thyroid drug you are going to use?
Carbimazole.
Right. Okay, so what does it do? What does carbimazole do?
It inhibits thyroperoxidase.
And therefore,
less production of thyroxine.
Exactly. It blocks the production of thyroxine. So therefore, you can see if the cause of excess thyroxine is due to the destruction of the cell, there is no excess production of thyroxine. So in which condition should carbimazole not be used?
In early stage of Hashimoto thyroiditis.
Very good. In Hashimoto's, there is no excess production. It is just the thyroxine that is they have been released. So therefore, please remember, in Hashimoto's thyroiditis, there is no place for carbimazole. I mean, you will see people writing carbimazole, but that's wrong. Please remember, in Graves' disease, there's excess production. So therefore, there is a need to block the production. Therefore, carbimazole is used. But in Hashimoto's, there is no excessive production, no need to use carbimazole. But in both, what do you get due to excess thyroxine?
Propranolol
No,
for
body.
symptom.
What do you get? What happens?
Hyperthyroidism.
No. What?
Decrease gravity.
High. What? Increase? Increase what? Somebody said increased what? Yes, increased what? In both you get features due to increased what?
Thyroxine.
Modi. It's not the thyroxine. Okay, so how does the thyroxine cause symptoms? Basically, what does it do? Come on, men. All of you know this. How does it produce all these things? Due to what?
Sympathetic overactivity.
Very good. There is the final mechanism of sympathetic coactivity. So therefore, in both, there is a need to control sympathetic activity using what? Using what? What do you use?
Beta blockers.
Yeah, what is the drug?
Propranolol.
Right. So in whom will you be careful when you use propranolol?
Asthmatic patient.
Yeah, people with bronchospasm and other conditions. So in those, what can you use?
Mm.
Hurry up. What is the other blocker? If you can't use a beta blocker, you can use a to stop the sympathetic overdrive.
Alpha blockers.
No, not alpha blockers. Mukada? Somebody say. No, not carb. Hey, kaude. Carbimazole blocks the sympathetic system. Kaudani, ulu palamale gani kauru. No, man, calcium blockers. Please remember, you can use calcium blockers. So either you can use beta blockers or calcium channel blockers. Both will achieve the blocking of sympathetic coactivity, and then the symptoms will settle. And that's what the patient appreciates most. Please remember, to block thyroxine production and bring results, it takes time and you can't wait till then. The first point in the management is control of symptoms. Achieved by what? What did we discuss? Lamai? Control of
Medical
symptoms.
man.
Medical management.
Beta blockers or CC.
Beta blockers or calcium channel blockers. Control the symptoms, and then with the other drugs, the imidazole group, that is a carbimazole group, they will block the production and then help the control of symptoms because the thyroxine will be gone. So that is how you do. Okay. මොකද්ද මේ ADT for 18 months and watch? මොනවටද බලන් ඉන්නේ වික්‍රමසිංහ?
Whether the
නෑ එහෙම නෙමෙයි මෝඩයෝ. What is the dose? Do you continue the same dose? Do you monitor it? Do you reduce it? Do you increase it? Do you decrease it? What is the maximum you can take? Kueva.
we usually start carbimazole in higher doses. Higher doses and then
hata doses නෙමෙයි higher doses. 8 doses උත් නෙමෙයි hata higher doses. නෑ මනුස්සයෝ 20 to 40 milligrams daily. Okay, ඊට පස්සේ
when we gradually reduce according to the symptom resolvent.
හොඳයි. Okay, right. Stop carbimazole when euthyroid. මේ කොහෙන්ද ආපහු පොතකින් කට පාඩමක් ගහගෙන ඇවිල්ලා මේ ගොන මේවා කරන්න එපා පුතා. You all must write your own thing. No, මේ මොකද්ද මේ කරලා තියෙන්නේ? නෑ. So you can start the drug at a higher dose, then drop the dose. Doesn't matter whether it is 6 weeks or 8 weeks when it is controlled. When the TTR is controlled, you can drop the dose and make the patient euthyroid. What can happen with a high dose? What can happen with high dose? Lamai, carbimazole high dose, what can happen? What are the
Due to
problems?
side effects, there
Yeah,
are
they can
side
be
effects.
side effects. What are the side effects?
Agranulocytosis.
Yeah, that is the worst thing. But what are the common things? What are the common
Fever,
other?
sore
Uh,
throat,
yeah.
fever,
Okay, so they are prone to more infections, right? What else? Respiratory infection. What else?
rashes,
Yeah, skin rashes, itching, that sort of problem. So if a patient gets this, you're worried they might go into agranulocytosis. What will you do?
change the drug to
No, no,
profile
no, no, no,
thyroid
no.
disease.
You have to check. No, it could be due to many things. So if you thought about a possibility of agranulocytosis, what will you do? Sorry?
Stop
Sorry?
the drug
No,
immediately.
no, no, you don't need to.
We
What
have
will
to
you do?
monitor with a full blood
Monitor
count.
Do a white blood cell.
Yeah, check the white count and see whether it is normal or abnormal. If it is normal and there is no issue, then this may be a temporary thing which will pass. You can treat it. But if there is any doubt, that is the time to stop the drug. Without evidence, don't just do things. තේරෙනවද කියන්නේ? That is subthalamic medicine. එහෙම කරන්නේ නැහැ. So you monitor them carefully and do all this. And then, okay, you can do. So how long do you continue the treatment? මේවා ඉස්සෙල්ලා 18 අර ඉස්සෙල්ලා 18 months කියන මෙතන 6 to 24 months කියන මේ යකා මේ ළඟ හිටියේ නෑනේ මේ වික්‍රමසිංහ ගොනා මේව පුතා කටපාඩම පොත්වලින් බලලා මේකේ ගහන්න එපා. How many times can I tell you? It doesn't make sense no. මෙතන 6 to 6 to 24 months. අතන කියන 18 months. මොකක්ද ඒකේ තේරුම? වික්‍රමසිංහ. ඔයි කවුද මේව ලිව්වේ? වික්‍රමසිංහ ඌ පැනලා ගිහලා. වික්‍රමසිංහ ඉන්නවද? පුතා වික්‍රමසිංහ වික්‍රමසිංහ
Hello, sir. Hello, sir.
ඉන්න ඔය හොඳ වෙලාවට ළඟ නැත්තේ මම හම්බේනේ ආපහු මට හරි ඔයි now what do you start at a higher dose reduce it then check levels etc carry on for how long do you carry on
Hello, sir.
කවුද
Sir, Bandar, sir.
Bandar how long do you carry on
We can give 2 years, sir.
no, you can do anything you can go to hell also that's not what I'm asking what happens commonly how long do you give
18 months.
right okay 18 months then what will you do then what will you do මොකද
We
what do you
can do thyroid
no
status, sir.
you don't do any bloody thing. The patient has now completed 18 months. Patient is euthyroid. There are no problems. Symptoms are all controlled. What do you? Patient comes to the clinic. What do you do? Hurry up! I have to. Huh? What do you do? Now you have to make. You have to advise the patient. What will you do?
We can stop the.
Yeah, of course. You stop it. So what will happen? You say you stop it and see the patient 1 month later. What are the possibilities? What might happen?
It's,
Bandara?
it's a recurrence of the disease, sir.
It may
Relapse.
happen. Okay. What percentage will recur?
50%.
50. Yeah, that's right. So, ඒක අනිත් පැත්තනේ කියන්න ඕන ගුණු. වීදුරුවක් half empty නෙමෙයි වීදුරුවක් half full කියලා කියන්න ඕන. ඒ කියන්නේ 50% are cured. You don't have to do anything. That's the end of their story. The autoimmune process has been stopped by nature. Done. So you don't need to worry about those patients. They are not going to get any problems. You can discharge them. The other 50% may get a relapse. Yes. That's right. So then what do you do? That is the question. Then what do you do? So 50% will get relapse. What do you do for that 50%? Ikman Karan?
So we can give radio ID.
Okay, you can, the possibility, there are 3 possibilities for those patients. What are they? Mandara? 3 possibilities.
And again start carbimazole.
Yes, that's right. You can try another course of antithyroid drugs. That's right. That is one option. Second option is to give radioiodine.
And surgery.
And surgery. Right. Okay. In what are the problems with radioiodine? Carbimazole we have discussed. What are the problems with radioiodine? Somebody quickly.
It completely destroys functioning thyroid cells
Anyway,
also.
yeah, in any case, after this autoimmune destruction, a lot of them will become hypothyroid later. So that's okay. That's a different thing. Yes, it destroys the thyroid and most of them will become hypothyroid later and will need thyroxine. That's okay. That's one problem. What is the other problem? They won't get worse. What? Disease won't get worse. What might get? In whom will you not use the radioiodine?
Pregnant woman.
Yes, all right. Pregnant ladies, obviously. Any other person?
The eye signs conversion.
Eye signs.
Yes, people with moderate or severe eye signs. What will happen? Eye signs will get worse. Please remember, it's not indicated in people with eye signs. Radioiodine. What is the other problem with radioiodine? In Sri Lanka? Also, what about the gland itself? The gland is very big, then it won't work. Okay, and also it is not freely available in Sri Lanka. So these problems are there. So what is it? PTU කියන්නේ මොකද්ද මේ බණ්ඩාර?
Propylthiouracil.
Oh, right. So what is the advantage of propylthiouracil?
It inhibits peripheral conversion of T4 to T3.
Right. Yeah. So what is this? What is special about it? Why mention that? No. Now see, once upon a time they thought PTU was a better drug. Nobody believes that anymore. What is the main problem nowadays associated with PTU, or has been noticed in certain PTU in patients, and in America there is a little warning also about that. So what is the common, or at least recently discovered severe complication with PTU? You all can go and read it. What is that? Anybody knows?
The hepatotoxicity.
Very good. Hepatotoxicity. Very good. So because of that, PTU no longer has that special place, but PTU can be used in certain people who are allergic to carbimazole and so on, and get a reaction. You can try PTU. Both. The other question about pregnancy and drugs is, what is the question? If a woman is pregnant and you have to start either PTU or carbimazole, what is the question you have to answer?
The trimester.
නෑ ටයිමස් නෑ මෝඩි උන්න මස්ටේකේ වුණත් ඒක නෙමේනේ ප්‍රශ්නේ. What about the drug and the fetus? What is the question? නෑ teratogenic නෙමෙයි යන්නේ. No.
Baby get alopecia.
නෑ අනේ. Question you have to ask is, does either of these drugs cross what?
Placenta.
Exactly. Does it cross the placenta? If it crosses, it will have the same effect on what?
The fetus.
Fetal thyroid. Exactly. So that is the question you have to ask. So please remember, in pregnancy, that's a very important question to ask. Okay. Does carbimazole cross? So in pregnancy, always remember that. Okay. By the way, when does a fetus have a functioning thyroid? At what stage? At what fetal life does it have a functioning thyroid?
8th week.
Very good. Correct answer. By about the 2nd month, they have a functioning thyroid, which may or may not be sufficient. So please remember, anything can affect at that point. So up to 8 weeks, the fetus is entirely dependent on the mother for thyroxine. So you must remember all these things. Okay. Right. So radioiodine we have discussed. How do you give radioiodine? Is it from a machine?
It's a solution given to drink.
It's a oral solution. That's right. So please remember, it's not a very difficult thing. You can do that. In some countries, of course, it may be the first line of treatment if it is freely available, because it doesn't involve very much. But we'll remember, but not in our. Go to that bloody slide. Right. Radioiodine for relapse. I am not sure, you can try, but if the gland is very big, this is not going to work. Okay, carry on. Yeah, Nand. Carry on.
So can we give both drugs in first trimester?
Both drugs.
The first month.
Yeah, that's a bit of a problem. But in general, the answer is yes. One is not safe. The people may prefer to give PTU because it works peripherally, not on the thyroid itself. See what I mean? So, but yes, both can be given with caution. That is the answer. But if you don't have anything and the patient is severely thyrotoxic, what is the risk to the fetus?
Neonatal hypothyroidism, fetal hypothyroidism.
Yeah, maybe. But more than that, what else can happen? What can happen to the fetus?
Neurological
Yeah,
system.
more than neurological. Come on, man.
Goiter.
No rubbish. No, man, it will abort. That's the problem. So you have to treat it. Okay. So you have to do it with caution. Yeah. මේ මුන් පොත්තලින් බලාගෙන මේ අපි කියවල ඉවරයි. Carry on. Okay. Go. මේ තවත් කොහෙද පොතකින් කට මේවා හැම ලියන් එන්නේ නැහැ මේ වගේ ඊට පස්සේ මම ඔළුව පලනවා දැක්ක හැටියෙම. Yeah, Regan. Okay. මේ ඔක්කො කතා කරලා ඉවරේ වනේ මේවා. හරි. No, this is true. Surgery is not the renal choice in younger patients. එහෙම කියලා කතාවක් නැහැ. You know, what if the younger patient responds, 50% of the younger patient responds to drug treatment? So, ඕක නෙමෙයි උත්තරේ. You try drug treatment in everybody. Okay? 50% will be cured, whether they are young, old, that doesn't matter. Then you get a group that will recur. And if the patient is younger in that group, then surgery may be better. Why? Why? Huh? Bandaru? In that group only surgery may be better, younger patients in that group which are recurred. In children and eye disease and large goiter, it's easy to understand. But why in younger patients it's better? Huh? Come on, think about it.
Risk of hypothyroidism is less.
No, man, what are you talking? Rubbish, fool. The moment you do surgery, they are hypothyroid. What else will they be? How
They will have drug resistance over time if they
resistance they will have to take drugs for a long time, isn't it? And compliance may be poor, they may get pregnant, various other issues come. So therefore, and children particularly, therefore surgery may be a good option in so, but you have to balance it. Okay, balance and take a decision. Don't be very dogmatic about this. There's nothing dogmatic. Please remember, first thing, drug treatment. See how it is. 50% cured. The other bits only you have to worry about various things. Okay. Page must be used total and කවුද මේ කැලේ ලියලා තින්නේ? කවුද මේ subtotal කැලලක් ලියලා තින්නේ ගොනා? කොහෙන්ද මේ බැලුවේ? පුස්කොළ පොතකින්ද බණ්ඩාර? What is the problem with the subtotal thyroidectomy?
So it's recurrence.
ඉතින් එහෙනම් ඇයි ලිව්වේ ගොනෝ? Not only that, how much do you leave behind? කොච්චර තියලා? කවුද දන්නේ? So therefore, please remember, if you are talking about surgery in Graves, there's only one operation. What is that?
Total thyroid.
Because not only that, the disease process affects what? What did they say? Total gland.
Disease affects the whole gland.
Exactly. So why are you leaving disease parts behind that? Don't write rubbish just because you copy it from something. Okay, total thyroidectomy is the operation. Okay, yeah. Side මේ ඒක ලියලා ඉවරලා මෙතන recurrence තියනවා කියලා ඒක දානවා මෙතනින්. හරි? මොන ගුණෙක්ද? So why do you operate at all then? නෑ ඒව ලියන්න බබුතා. තේරුණා මං කියන්නේ? So patient all that. Okay. Right. Hari. Any questions? Thank you. Hari, any questions? Anybody? Any questions? Lamai? And Graves is any of homework, who is Robert Graves? various types of receptors. ඒ ඔක්කොම බලාගෙන ඉන්න ඕන මම අහනවා. හරිද? Okay. Any questions? ළමයි කවුරු හරි answer කරන්නද? question තියනවද?
So when we do not consider about the availability of the drug, so any therapy, what is the therapy of choice is the drug. So the radioactive iodine, I mean,
please
the best one.
ever get don't ever forget why you haven't listened to any bloody thing. Listen, Graves' disease, the main treatment is drugs. Anywhere in the world it is the same. So if a patient has Graves' disease, the best choice is to treat it with drugs. Again, because why do you think? Tell me why do you think it is the best?
There's a 50%
exactly 50% will be cured. So if you ask what is the choice of treatment in Graves' disease, the answer is quickly
drugs, antithyroid.
Exactly, drugs. Graves' disease is a medical condition, and surgery and radioiodine for people with various issues. But radioiodine may be used by some people. But in general, Graves is a medical condition. Therefore, the best choice is drugs, and 50% will be cured. That's what you must remember. Is it clear?
Yes, sir, thank you.
Yes, sir.
Yes, sir.
Right. Okay. Any other questions? Okay, if there are no questions, we'll end this session. We'll maybe ඔය වගේ ගොංගේ වලියන් આવත් ආයෙත් මම කරන්නේ better write better than that. Okay, anyway, okay. We'll finish.
Thank you, sir.
Okay.
Thank you.
Thank you.
Thank you, sir.
Recording stop.